Good afternoon, everyone. My name is Meg Snook, and I am Administrative Assistant with the Regional Palliative Care Leadership Team here at the Miller Center in St. John's. I'd like to welcome you to our Palliative Care Grand Round webinar. Today's topic is an interdisciplinary approach to nursing intervention with palliative patients. And this session is being facilitated by Lana Park, and Lana Park is a social worker with palliative end-of-life care. Time permitting, Lana will answer questions at the end of the presentation. And if by some chance we run out of time, then you can email me, margaret.snook@easternhealth.ca, and I can forward them to Lana. At the end of the presentation, to ask a question, you can just raise your hand, and I will unmute you in order for you to speak and ask Lana a question. Just to let everybody know, I will be recording this session, so just in case, I prefer that you didn't talk or have any noise, because this recorder picks up every sound, and if anything is mentioned on it in the background, then I cannot put the recording on the intranet. So just want to let you know that. So I'd just like to take a few minutes now, and I'll change presenter over to Lana.
All right. Think that okay, Meg, there now?
Yes.
You see my screen? Okay, good. Perfect. So welcome to the webinar. As Meg have said, today's topic is an interdisciplinary approach to nursing intervention with palliative patients. My name is Lana Park. I am a social worker. I've been involved, I guess, in the profession for about 20 years, but specifically the last 7 years, I've definitely had the privilege of working with patients and their families who are palliating and very close then to end of life, and doing some bereavement care after the palliative process. So in today's webinar, to be honest, I've changed my way of thinking and presenting it a little bit. So most of the presentation will be around the social work profession and enhancing care to our palliative patients through a nursing intervention approach. In the presentation, I will talk specifically just to do a little bit of basic information around palliative care in general. So we'll start with the definition of palliative care that is by the World Health Organization. So palliative care is an approach that improves the quality of patients and their families facing the problems associated with life-threatening illnesses through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. And out of this definition, one of the things I guess I want you to really pay particular attention to is the focus on patients and their families. And that is definitely very much a social work approach to care. And the piece around other problems associated with pain, such as psychosocial pain and spiritual health. And we'll talk certainly in depth about that more as we go through the presentation. So the goal of a palliative care approach, of course, and I know nursing staff and all other Eastern Health staff obviously have these particular goals in mind, because it's the achievement of the best quality of life for our patients, and again, and in palliation, very much considering the patient's family. So that's kind of what we're all working together to achieve. So when do we begin palliative care? And this is an important piece of information that I definitely want people to think about. It's never too early to begin a palliative care approach, because that's what it is. It's an approach to care. And it's any time during a person's life-threatening illness from diagnosis on. So, you know, sometimes we talk about palliative care and end-of-life care interchangeably. And that can be a little bit confusing sometimes because palliative care is an actual approach to care. We begin it early. End-of-life care is certainly a little bit different than the palliative approach because usually at that stage, people are actively dying. So the palliative care approach is something that in my role, very specifically, I can begin working with patients right from the beginning of diagnoses. The next slide talks a little bit about benefits of a palliative care approach, and again, this comes from the World Health Organization. So relief from pain and other distressing symptoms, and I'll talk again a little bit more about that. The distressing symptoms that we think about would definitely be very much coming from a whole person or holistic approach, and I'll talk about that as we move forward a little bit. But it also can help people affirm the dying as a natural, normal, healthy process. So it really gets people thinking about and talking about it as a normal process. It looks at the integration of the psychological and spiritual aspects of patient care and health. And again, we'll talk about the holistic approach as we move forward. It offers a support system to the family. And that's one of the things that in this particular type of care I've noticed significantly in my last 7 years working with palliative patients is that the support to the family is often critical in order to ensure that a person has the ability or opportunity to die with dignity. Also, it's applicable early in the course of illness, which is something that I just alluded to. So who benefits from palliative care? Those who have been diagnosed with serious life-limiting illnesses, who desire relief from pain and symptoms that are associated with their particular disease. So, it might be, as an example, a patient who has an ALS or an MS diagnosis, who, may not necessarily have 6 months to live, but might have 5 years to live. That particular patient would be somebody who could benefit from my particular service, again, recognizing that that's not necessarily end of life. Those who need to make difficult decisions about how to proceed, that is definitely something that I do a fair bit of work around. And in particular because sometimes our patients and their families don't have the same wishes or desires in terms of how to proceed. So it's really trying to make sure patients' wishes are recognized and working with them and their families to kind of move forward. And those who need assistance with communication issues related to their care. And we do see a lot of that in terms of sometimes people having communication issues, whether it's coming from professionals to patient or patient to their families, but oftentimes getting in and working with the patients and their families around talking about their care and having the good conversations are very beneficial to both the patient and their families. And I guess, trying to educate patients as well about the fact that there is more than physical pain. There are other types of pain that may actually be attributing to your physical pain. And again, that going back to emotional health and spiritual health and those other aspects of care that are so critical in terms of overall wellness. I wanted to, I guess, bring up this particular slide to kind of say who we have here in Eastern Health that are specifically doing community palliative care social work. So again, about 7 or so years ago, I was hired, and it was actually the first position of this type in Eastern Health to look at community palliative care. So for social work, I cover the Clarenville, Marystown, and Bonavista Vista area. I am physically located in Clarenville at Kosh Place. Obviously, based on geography, and I've had this conversation with many people, the services provided from me might look very differently, but I still encourage and recommend people at least consult with me, and I can link you to appropriate services, certainly in your own communities, and or provide consultation with other social workers in your communities to kind of provide the care that would be beneficial to the patient and their family. Gary Parsons is located in St. John's, He covers the St. John's area. Both Gary and I do lots of, we do home visiting, and we certainly see patients in patients and or their families in our office setting as well, if that works better for them. In rural Avalon, it's certainly set up a little bit differently for now. It has been recognized, it has been brought forward, and it's something that's being worked on. But right now, it is based out of the Carbonear Hospital. It is actually rotated amongst approximately 6 social workers, and they do have the ability now to take some patients on and provide palliative care social work services. Referrals to social work. So how would you make a referral to us? On the intranet, the Eastern Health intranet, you can find the interprofessional referral for assessment / service form, and that is located under the community support program. And if you just go into form, then you can find that particular referral, and it's CH-1293. For myself and Gary, certainly phone us. Our phone numbers are listed, and you can have a copy of this presentation afterwards if there's a need or want. And or you can email or scan us the referral, and we would respond to that for sure. For the rural Avalon social workers, they have an email address set up, palliative care ra@easternhealth.ca, so the referral would be sent to that, and then they look at the referrals and assign a social worker. Social work approach. So one of the things, like all professionals that we do as social workers, is we very much look at the screening, assessment, and intervention stages with our patients and their families. In the screening phase, I guess what we're really looking for is psychosocial screening, which would identify patients and families that have a high level of distress. So really trying to figure out what their stressors are and what is causing them the issues, and really then doing some goal setting around their particular wishes. The assessment piece is a very multidimensional, holistic approach where we look at all aspects of a person's life. And on the next slide, I'll talk a little bit more about the aspects of the person and their family's lives and how they all kind of interact and what we would be looking for. And then intervention. This is usually provided through, we usually look at solution-focused brief treatment models that very much are focused on patients' needs and wishes. And I'm not going to get into specifics around solution-focused or brief treatment therapy models, but basically these types of therapies and treatments would be, again, very solution-focused and look at patients' wishes, their families' wishes, and setting up very realistic, attainable goals to kind of move that forward. So in terms of what affects an individual who has been given a diagnosis that is life-threatening, we talk about what Woodruff would talk about as total suffering. So in the diagram there, you can see right in the middle would be the person and their family who's experiencing all of these particular, I guess, thoughts and problems that come along with the palliative type of diagnoses. And on the outside, you would look at what specific things are attributing to that particular individual's suffering. So you want to do a really good assessment and figure out which particular pieces need to be, I guess, paid attention to and focused on. So for example, one of the things I've noticed socially with palliative patients, if you have a really social person who's now become, you know, kind of confined to a home and really struggling with not being social or not really having the motivation to be social, that might be something that is a major focus and attributing even to physical pain, believe it or not. So it's important to kind of really dig into the specifics of which aspects of these people's lives are actually the most complicated for them at this particular time. And having the patient's wishes and the family's wishes being your goal as well as theirs is definitely worthwhile in terms of moving a person along the journey of palliation and then end of life. roles of community palliative care social worker, I thought it was important just to, I guess, educate people around some of the work that potentially might be helpful to your patients. And in particular, nursing staff would sometimes refer to us, knowing that these are some of the things that we could hopefully help the nursing staff with in terms of moving a patient forward. So advocacy is definitely on fond and a very big one in community palliative care, because it's a relatively new kind of idea, although years ago they did palliate in communities. We kind of went to a stage where most people were palliating in hospital, but now we're kind of trying to move that back to the community if that's the patient's wish. So we do a lot of advocacy, ensuring patients and their families' wishes are kind of understood, making sure that they can avail of services, and connecting them to the appropriate services and resources. So it's advocacy in that area of linking to other community agencies. Communication is something, I guess, as social workers that we spend a lot of time, even in school, kind of building skills around how to communicate with people. And so one of the things I think that we would be able to bring to the table is the ability, hopefully, to communicate with the patients and their families and the team, so the nurses and physicians who might be involved in their care. And we really try to focus on open-ended questions and open-ended conversations. So, rather than saying to somebody, do you have pain, we would talk about, so, how is your pain today? And just giving them the opportunity to have a conversation, and conversations happen much better when we use open-ended questions. Information sharing, we definitely do lots of that. So appropriate information, support, and resources, giving them that information often allows the patients and their families to feel a little bit more acceptance. They feel a little bit more educated and a little bit more able and willing to kind of take on some of these really difficult things that they're now faced with. Some continued roles, I guess, for community palliative care social work would be counseling, and this is one of our biggest, I guess. In particular, I can certainly speak for myself, and I think for Gary. We definitely do lots of individual and or family counseling, and examples of the types of things we would be doing. So for a patient, it might be adjustment to the diagnosis, the actual end-of-life planning. So it could be, looking at making sure they're connected to people, and talk about the importance of wills, talk about the importance of advanced healthcare plans. And we do a lot of counseling in the area then of grief. So if we've seen a patient who we've seen through the palliative process, and then their loved one dies, we would definitely follow up with that particular family member or family members and offer some grief work after that. And I just kind of had a little in brackets there, including anticipatory, and there I'm talking about anticipatory grief. So of course, what I'm referring to there is if you have been giving a diagnosis of life-limiting illness, you're probably yourself and your family have likely experienced some anticipatory grief. They're already grieving while they're still potentially palliating. The other thing around the counseling that I feel like I do a fair bit of is when you're given, a family member is given a diagnosis, oftentimes there's a lot of family role changes, and there's oftentimes a lot of work to be done in that particular area. So we focus a lot on, what your role is now, how is your role now meaningful. People need to have purpose, and the purpose is often usually found from the roles we provide in families. So it's very important to have, do some work with the patient and or the other family members to look at, kind of how they fit into this picture now, and what their new role might look like. So as previously mentioned too, we often do, we kind of try our best to ensure we're doing a thorough assessments. And these assessments include very much the holistic perspective, which I alluded to before, included psychosocial health and spiritual care and all these other things that sometimes may or may not get overlooked, but they're certainly critical to overall wellness for sure. And then, you know, we try to, of course, work as a team. One of the things, I guess, that I want to say here, even when we're talking about our roles of palliative care social work, one of the things that I've quickly learned, I think, is that, you know, we need to meet our family and patients' needs by meeting them where they are. And it's their goals, it's where they want to go. So I very much try to meet patients and families where they are and work with them from there. Sometimes that can be frustrating because we don't even know, you know, we may not agree or think that's the best thing, but what we do need to recognize is that's their wish and their right. So we need to kind of keep those things in our head as we're moving forward. I just wanted to speak to a little bit around like the direct practice stuff. So what am I doing? What am I talking about in terms of when I'm addressing or talking about psychosocial needs and health? So I just indicated here, reducing emotional and or physical suffering. And one of the things, of course, again, that I think I kind of already alluded to in this presentation is that emotional health impacts physical and vice versa. So working on one will hopefully have an impact on the other. So recognizing that is kind of important and crucial. Reducing family conflict. Often, again, you know, when one particular member is given a life-limiting diagnosis, it changes the whole family dynamic. We refer to it sometimes as like a baby mobile, if you can picture it. If one of these people, if their role changes and there's major change, then the whole family changes and the mobile is tipped. And if one person is no longer, I guess, as stable as they were, then it throws a different dynamic into the whole family for sure. Help manage pre-existing or co-occurring mental health issues, and this is a fairly significant issue that I come across a lot. So I might have a particular individual who was just given a cancer diagnosis, who has already been treated for anxiety and depression. So co-occurring mental health issues is it seems to be pretty common, and what we need to look at then is how do we help treat the anxiety and depression, because those particular issues are going to have an impact on the physical health of the other diagnoses, which may be cancer or could be something else. So we will look at, or I certainly look at, I have a previous background in some mental health counseling, so I would look at cognitive behavioral therapy, making sure we're looking at addressing the anxiety, depression issues. It might be that maybe, it needs to be referred out to the mental health program or to a psychiatrist or psychologist. So about making, again, these linkages. Face fears related to illness progression and thoughts of dying. And that's a really big one too. So it's about opening up conversations. I will say to you that generally the reason I always talk about getting involved a little bit early is these are very difficult conversations, and it takes a while to build up a good rapport. Once you have that rapport, you're able to get to these places, such as having the really deep conversations about the dying and their wishes and those kinds of things. And the last one there that was mentioned is bereavement care. So often, and this relates to once you've actually lost your loved one, we will do some grief work, bereavement work, and I'll address that a little tiny bit later with a little bit more further information. So some of the important communication topics that we would be talking about would be end-of-life decision-making, which would include things such as, an advanced healthcare directive, wills, all those kinds of legal type things as well that we really want people to have some discussions with their loved ones about. The thought of suicide or wanting to hasten death, it's not uncommon in my work with palliative people to have patients who, have the thought of, I wish I were dead. Not necessarily a plan, but certainly have kind of morbid thoughts, I guess. So it's talking about those things, working those things through. Anxiety about death is often some important things to consider, because some people are afraid of dying, and kind of looking at that particular issue and addressing it. Preferences about their environment, where they want to die, when they would, do they want to die home, do they want to stay there, do they eventually want to go to hospital? So again, really deep conversations about very touchy subjects for people. Social supports are a big one, and I think I alluded to that before. Informal and formal supports are really important for palliative patients, absolutely, and it makes the whole process a much smoother transition. Financial resources, I'm finding more and more that this is becoming more of an issue for families, and unfortunately financial resources really, and lack thereof, really impact the ability to die with dignity. So we really need to kind of look at that and link them to appropriate services. I will say in my social work practice that I've always been a believer of, you know, if you don't have basic needs met, it's really hard to get to the very deep counseling conversation. So I always go back to, let's meet the basic needs first, get them financially straightened away so that we can get to, you know, the more counseling, deeper conversations. Safety issues, that's a big one too, like making sure, I think about some people who, you know, want to palliate even maybe at home, but they don't really have anybody. So it's working with them to talk about, you know, the safety of that particular issue. Comfort issues, and that can be non-physical in terms of, it might be things that we talk about like relaxation, meditation, deep breathing, those kinds of ideas. Complicated anticipatory grief, that refers to basically, again, if you've been given diagnoses and now you're already grieving what you once had, we talk about that and we identify it as this is probably what's happening, and have some good conversations with people and their families about that. One of the things here that I want to say is I try to do a little bit of work with people around opportunities to resolve conflict. And that would kind of be covered here. And the reason I would do that is because in grief after palliation, what I normally see, if people have complicated grief, it's often because they haven't been able to resolve issues. So I always talk to my patients about, are there things that you need to work through? And that's an important conversation to have with your patients. Awareness of the prognosis. It's interesting here because I often have lots of conversations even with healthcare providers about denial, and you know, you can't, I guess the only thing I would alert people to around denial is some amount of denial, and I've read this in several places now. There's actually, you know, people go in and out of denial, and I think a lot of that is self-preservation. So it's working with them around that particular issue, and accepting that denial is pretty common coping technique of for people who have life-limiting illnesses. And spirituality, I will say that spirituality is something that I feel is quite meaningful for people in terms of having good death, and there is such thing as good death. And again, not necessarily religion-based spirituality, but higher purpose in life, a sense of connection, a sense of meaning. So it's about trying to find, help people find that for themselves, because that's pretty important stuff. I do want to tell you that this social work assessment tool, otherwise known as SWOT, it is not something that's approved. It's not a form you will find on my document in my files. But in my research, when I first started this position, it was something that I used to help me figure out what are the conversations I need to be having with families and their primary caregivers to ensure that we're kind of helping people palliate the best we can. So it is something that I used. It's an assessment tool. It's a social work assessment tool. So again, although it's not on my charts, it's something that it's always in the back of my head around what are the conversations that I need to be having, and the things that I just identified for you on previous slide is what was listed there. So basically you ask the patient and the caregiver, like, you can talk to them about those issues and get an idea of where they are, and try to help look at which particular things are most meaningful to them and how we can work through some of that. This particular quote is just a quote I thought I'd share with you. It says, "Good palliative end-of-life and bereavement care relies on a range of formal and informal supports." And I've already said a couple of times, it's one of the kind of takeaway messages, I guess, that I'd like for people to hear, is palliative care is really hard work. It's not something that one person is going to be able to provide for a family. Now, obviously, as nursing staff in particular, they definitely need to be a part of that palliative process. But bringing other people in to help assist with some of these things might be quite valuable for the family. What is the goal of the community palliative? So when I think about goals around community palliative care, we want to continue to work to enhance our work as a team. So basically, I think, and I think most of us think, we're doing, people are doing some good work in the community in terms of palliative care, and I certainly know lots of nurses who are providing very good hands-on palliative community care. So we want to just continue to build that, and want to support each other in that, and work together to kind of see if we can continue to move it forward. We need to recognize the barriers, which I think lots of us do, and we talk lots about it at the frontline level and at management level, and we need to think about solutions and suggestions, and we need to reach out to people who may have the ability to help. So for example, if you're a nurse out there providing hands-on palliative care in the community, and you kind of haven't made a connection with me before, and you think, oh my, maybe I could use a little bit of a consult, absolutely. There's no reason not to pick up the phone and have a bit of a conversation, for sure. These are just a couple of little tips that I thought we would kind of mention and think about. Rearranging living space at home. I just was at a home not real long ago where there was going to be a bed delivered, and basically I guess the conversations were, they didn't want to be in the bedroom because they wouldn't get to see or hear the family as much, so we basically, the bed was put right in the living room. So something as simple as those things are really important and meaningful to families. And when you're in the middle of emotional distress, you're not really able to focus and think. So sometimes helping people come up with some of these solutions is pretty meaningful and pretty minor for us to do. Having the right equipment, and oftentimes, of course, nursing staff is involving OT and making sure we have equipment in there to keep them at home and as comfortable as they possibly can be. And the wishes of the person receiving the care. So having open conversations about when or if there's a desire to go to hospital, but really having open conversations with the person. And, it's not easy conversations, and unfortunately they take a lot of time oftentimes. So again, that's why I guess I say to people, reach out to others, engage other people to help you with this, because it's a good chunk of work, for sure. And post-death planning, and that's something that if I'm connected to a family, that I will often have conversations about as well, making sure they kind of, know who they're going to call when Dad passes, and are the funeral arrangements in place, and just having a bit of a plan, because I've also seen the other side when those things are not ready, and it becomes very confusing and frustrating to families at a time when they're already quite emotional and I guess emotionally unwell. I want to talk to you just a little tiny bit about bereavement, and the reason I felt I had to push this in there is because it's a fair chunk of work that I would do, and I think that most palliative care type social workers would do, in particular if they've already followed the family throughout the palliative process. So there are times when a new grief referral comes to me and I wasn't a part of the process, that I would pass that on to, for example, the mental health social workers. But if I've been a part of their process, if I've been a part of the palliation and the diagnoses and all these kinds of things, then I would definitely do some bereavement care with the family members after. So the bereavement is a period after the loved one dies when grief is experienced. And I'm sure most of us who are on this webinar today have experienced some type of loss. And grief is very difficult work. It takes a lot of hard work, and sometimes we may need some formal supports to help us through that. So I definitely would follow up with the family after their loved one passes on, and I would definitely kind of try to normalize grief. And that sounds a little strange to some people, but grief is a normal, it's a natural, and it's a healthy process. So I provide lots of education around that. We often talk, people who do a lot of grief work will talk about grief as a wave. So you would often hear the old cliche of time heals, and we kind of say, well, there's some truth to that, but it's not really true, because if we don't process the grief, if we don't work through it, then as much time can pass as we want, we still haven't done the work to kind of journey ourselves to a normal, healthy grief reaction. Waves, when I talk about waves of grief, basically what we're talking about is, we will experience some bad times, good times, and somewhere in the middle. Hopefully, by working through it, by talking about it and processing it, these waves become a little less and a little more infrequent. And we help individuals and families deal with emotional and practical problems associated with the death of a loved one. So really just emotionally and practically helping them kind of move forward with where they are as a group. I do want to talk just very quickly about individual and group work. We do both. And I would tell you that if you ever have the opportunity, or if you yourself ever go through grief reactions, if you ever have the opportunity to do some grief counseling, or it's an interest of yours, the group work is a very powerful process. I've done lots of individual sessions, but I always go back to my grief group sessions where I guess people who've been through very similar experiences support each other. And I have people come into that group who were very hesitant in the beginning, but eventually you recognize that they really value the other's opinions, and they do lots of their own great work. It's truly just a facilitation of their own really good work. So that's something to keep in mind as well. And lots of times there are different grief sessions offered, certainly throughout the Eastern region I can speak to. So I would highly encourage, if you have a patient who you feel could benefit from those types of services, to recommend them for people. I just wanted to provide just a little bit of a case example, and this is, I'm just going to run through quickly a couple. And basically these particular examples are I just wanted to list kind of the types of cases, or some of the cases that I might be connected with. So this particular case is 45-year-old male with progressive MS. Patient requires assistance with all ADLs. Spouse is providing all caregiving needs. 12 and a 15-year-old child or children at home. Lives in a rural area. They have family issues. There's low income. Not willing to complete a financial for service, and very high levels of stress. So as you can see, it's a pretty complicated case, and I often think about, you send a nurse down, or even a community support social worker down, and this is what you're facing. It's kind of like almost a bit, well, where do I even start? So there is a lot of issues that need to be teased out there and kind of worked on. To see if we can kind of get this family to cope in a way that they're managing. When I will do any work with, again, any of my patients, I very much do a client-focused session. So when I'm going in, I'm trying to first build rapport, talk about their goals, what they want. Coming in to tell them what they need or want is certainly not beneficial. But really kind of having a good discussion with them around what it is they feel we could be helping them with. And unfortunately, these types of discussions take a lot of time. They don't happen in 10, 15 minutes. And I recognize for some for some staff, that's a real challenge because you're kind of, you're bouncing from one thing to the next. But it really requires deep conversations, which can't happen very quickly. So in this particular case, I really had to try and start teasing out, what we could kind of get to first that they were willing to let me in at and let me help with, and what they were, I guess, kind of identifying as the major issues. So eventually there was definitely, a bit of work to do around the financial piece and the reluctance around doing any financial piece, and referring out to other services because of the family dynamic issues. So for example, if I'm working with the particular patient and their family, but yet there's a dynamic with a child, I might often refer that child to another service provider if they need their own individual work, because it can become quite complicated when we're providing individual work to all of these individuals. It kind of is perceived by family as who she's supporting. So if it's a family type of issue, then yes, absolutely, I could do some of that work. But if there's more of a particular issue with a particular person, it might require the teasing out of, do we refer out elsewhere? And with the family in particular, there was a lot of this particular family, a lot of counseling regarding the adjustment to a life-changing diagnosis while still parenting. There was lots of conversations about trying to really kind of give this person back a sense of meaning and purpose, because he felt he was robbed of that and that he was no longer able to help out this particular family. But in fact, when you dug a little bit deeper, you could see that there were still certainly ways he was supporting and providing for the family, but it was really hard for him to grasp that. So it required lots of, and still requires lots of reminders and conversations. So that's an example of a case where, it might be too much for obviously one individual to try to be working with this particular family, and we need to be probably connecting to other resources or looking at how we can best meet the need. Another example is a 68-year-old man, recent diagnosis of metastatic pancreatic cancer, no treatment, and advised to get his affairs in order. Has a 75-year-old wife who can assist with caregiving. Children all reside outside the province. Limited support system because they're new to the area. So that's another kind of a good example, because in palliation, in grief recovery, and any of those things that we've talked about here today, it's very clear that people who have a good support system do much better. So if you have a really limited support system, connecting them, having this particular, and I think about this lady who just kind of felt, maybe I didn't do a whole lot, but just the ability to know I was there to pick up the phone if she had to. And I find lots of times, lots of these cases don't require a whole lot more sometimes than actually knowing you're there if you really need them. So it's important, again, to kind of reach out to others. So when, again, you're working with a family like this, you need to think about the client's goals, the family's wishes. You need rapport building is extremely important, which is why in the very beginning of today's meeting I talked about, or webinar, I talked about it's really important to kind of get connected as sooner than later, because it does take a while to build up a rapport in order to have deep conversations about death, dying, changing family rules. They're pretty heavy topics. And again, we talked about the importance of very open-ended conversations and questions. I would definitely help this particular family with navigating systems. They're new to the area. They might not understand kind of the way things work here. They work a little bit differently. They came from a different province. So we're trying to help them manage some of those things. And information sharing, referrals to appropriate necessary services, which I've definitely kind of already alluded to. This is just a little bit of a conclusion, I guess. So it says nurses provide an essential and valuable role in providing quality palliative care services to patients and their families in the community settings. Recognizing the benefit and value of adding social work holistic approach to patients and their families will further enhance the quality of care provided. So if you think about it, you know, our goal, all of us, I'm sure, who works with palliative patients, is to provide the best quality care we can. Sometimes we get frustrated and we might not even be able to get all the things we feel like that would be very helpful, or might not be able to get access to things that we're looking to get access to. But we got to work together on these particular issues. And so reach out, have the conversations with other people, while recognizing, again, you know, sometimes there can be some frustrations, but continue to reach out, and definitely, if you feel you have a family that could benefit from social work services, certainly feel free to consult with me. Absolutely. And this one, which I think I felt I put it right at the end because I thought it was very important. It says, everyone providing palliative or end-of-life support needs to be supported themselves. I think that's a very powerful statement. And this was from the National Palliative End-of-Life Care Partnership. And I think it speaks volumes, because palliative care and end-of-life support is very challenging work. It's not something that happens very easily. It's very rewarding work, though, I would say, at the same time. So when we see good quality palliative end-of-life care happening, it's very, very, very rewarding. So reach out to each other, support each other through these cases, because we all recognize at times, you know, people are really busy, they're running through their day, but we need to be supportive of our coworkers, of our and of our staff to recognize this is truly really challenging, difficult work. I hope people were able to get a little bit of something from today's webinar. I will open the floor, I guess, now in terms of if there's questions. Certainly you can type them in, and I guess Meg will let me know. And if there's anything I can do to assist, certainly feel free to consult with me. Thank you.
Okay, if anyone has a question, you can raise your hand in the box and I can unmute you, because I have a lot of lists here. So I'm going to scroll down now and see if there's any hands up. And if there are, I certainly will unmute you and you can speak to Lana. Okay, I don't see any hands raised, Lana.
Right.
Okay, so I'd like to thank everyone for joining today's webinar. And I wanted to let you know that our next webinar will be on January 23rd. And our topic will be palliative care, end of life, and the maintenance of dignity and keeping it real. So that is already advertised on the Eastern Health intranet and also under the calendar of events. So I'd like to thank Lana for today's presentation. So thank you, Lana.
Thank you.
So that ends our webinar for today. And thank you.